Hi guys, good evening, good evening, good evening. Can you all see me? Can you all hear me? Hi guys, can you all see me? Can you all hear me? Quick feedback. All right, so we were talking about intestinal obstructions. Okay, so continuing on the same series, I'll be talking about dynamic bowel obstruction. In the dynamic bowel obstruction, I would like you to meet one of our very famous guy, that is your intussusception. Now, by definition, what is intersusception? By definition, it is defined as if one loop of bowel, telescopes into another. If one loop of bowel telescopes into another is what we call it as intersusception. Hi guys, good evening, good evening, good evening. All right, sure. So by the definition of interception, if one loop of bowel telescopes into another, what is that one loop telescoping into another? Basically, when we say if one loop of bowel, this is the proximal end of the bowel. This is basically the proximal end of the bowel telescopes into another, that is a distal end of the bowel. That is going to be the distal end of the bowel. Now, what do you mean by this? Now, just for the sake of understanding, let's take this as a representation. Let's say this is the bowel loop that we're talking about. See, for the sake of understanding, I'm going to divide the bowel loop dead in the center, and the content is going to move in this particular direction. ठीक, so ये content का direction है कि ये इस direction में बावल का जो कंटेंट है मूव करेगा. तो ऑब्वियसली जिस डायरेक्शन मूव करे इससे पहला वाला जो पार्ट है, द फर्स्ट पार्ट इज व्हाट वी कॉल इट एज द प्रॉक्सिमल एंड ऑफ द बाउल. इसके बाद वाला जो पार्ट है, दिस इज व्हाट वी कॉल इट एज द डिस्टल एंड ऑफ द बाउल. सो नाउ यू हैव गॉट टू पार्ट्स दैट हैव डिवाइडेड. This is going to be the proximal end and this is going to be the distal end. So what is an intersusception? If the proximal end of the bowel telescopes into the distal end is what we call it as intersusception. So all that you have to imagine that this end of the bowel is now going to move inside the distal end. We'll tell you why it is going to happen, how it is going to happen, but let's try to understand this. So if this is the bowel loop, the proximal end is forced to go into the distal end, and the distal end is going to accommodate this lumen. This is what we call it as intersusception, where you can see, if I highlight, this becomes the proximal end. I'm highlighting in green. This becomes the proximal end of the bowel. This proximal end of the bowel is now moving into the distal end. It is now moving into the distal end of the bowel. The proximal end of the bowel has now telescoped. The proximal end has now gone into the distal end. It is telescoped into the distal end. Now, what is the problem? The problem is, because of this, the content that is present inside the bowel lumen will now try to go. Now, as it hits the roadblock here. Now, because it is going to hit the roadblock, the content cannot move any further. As the content cannot move any further, it will result in intestinal obstruction. So, simple सा concept ये कि intestinal intersusception में the proximal end of the bowel, this is the proximal end of the bowel when it goes into the distal end of the bowel. The proximal end of the bowel, when it goes into the distal end of the bowel, it is going to clog the lumen, and the clogging of lumen will cause intestinal obstruction. This is what we call it as intersusception. Now, the part of the bowel loop that has gone inside is what we call it as intersusceptum. So, the green one is what we call it as intersusceptum. And the one that is accommodating, this is called as intersuscipiens. Right? So one that goes in is what we call as intersusceptum. One that accommodates is what we call as intersuscipiens. And you will notice the maximum injury is going to occur into the middle surface, or I can say the middle layer. Right? If I have to highlight, this is the inner layer. This happens to be the outer layer. In between these two, this is your middle layer. So the maximum injury is going, because this is going to get sandwiched between these two layers. Now this sandwiching between these two layers is going to cause maximum damage, right? So this is the whole concept of intersusception, when a proximal end of the bowel loop goes and telescopes into distal end, resulting in clogging of the bowel lumen, not allowing the content to move from the proximal to distal, resulting in intestinal obstruction. Is what we call it as, or is it, this is what we known as your intestinal obstruction or dynamic bowel obstruction secondary to intersusception. Now, why this occurs? Why does the bowel telescopes? So there's a concept. Okay? So there is a small concept of lead point. Now, what is this lead point? It is a point from where the intersusception begins. Lead point is described. This is the point. This is the point from where intersusception begins. So it's the start point of the intersusception, and that is what we call as lead point. Now this lead point varies from different age groups. Usually you will see intersusception in babies between 6 to 10 months old. Now here it is because of your diarrhea under the age of 1 year. The most common cause of diarrhea under the age of 1 year is rotavirus infection. So here it is seen post rotavirus diarrhea. Post rotavirus diarrhea, these babies will develop hypertrophied. They will result in hypertrophied Peyer's patches. They will result in hypertrophied Peyer's patches. Then if they ask you what is the most common lead point in children, overall most common lead point in children, it is going to be your Meckel's diverticulum. This is going to be your Meckel's diverticulum. If I change the question and ask you what is the most common lead point in adults, the most common lead points in adults is going to be polyps, and that too of villus polyps. It is a villus polyps. If I change the question, what is the most common lead point in children? In children as tumor, that is going to be small intestinal lymphomas. It's going to be a small intestinal lymphoma, right? So these are the various lead points that you have to remember. That is going to be from an exam perspective. I'm not worried about it. Let's take any one. For a matter of fact, let's talk about Meckel's diverticulum. We have already spoken about it before. Now, if I take Meckel's diverticulum as a lead point, let's try to decode this. Now, let's say this happens to be the bowel loop. This is where the Meckel's diverticulum is present on the anti-mesenteric border, and this is the bowel loop that is present. So, where the lead point is present, that is what we call it as point 0. Before this will be called as the proximal end of the bowel, and after this is called as the distal end of the bowel. Before this, we have the proximal end, and beyond that, it is going to be the distal end of the bowel, and the lead point is what we call it as point 0, right? Akash, I got your request. Soon after this class, I will share uh, the gastric volvulus notes also. Okay? Now, these are the proximal and the distal end. Now, what happens is, we all know the peristalsis works in tandem of primary and secondary contraction, right? Now, what is a primary contraction? What is a secondary contraction is? Let's say this is the lumen of the bowel. Whenever the content comes up, the area where the content is at that end of the bowel is going to contract. Distal to that, it is going to dilate, and the rest of the bowel remains in a collapsed state. This is what it is, right? So where the content is going to be present, that end of the bowel is going to go into contraction. This is what you call as primary wave of contraction. Now this primary wave of contraction exerts pressure on the distal end, it dilates. Because of this, the content is going to move forward. Now once the content moves forward, what is going to happen? This contraction will release back. Now as it releases back, it will regain its normal component. Now as it regains back, it relaxes, this will also recoil back. Now once it recoils, this will also come back to its normal position, and obviously the rest of the bowel distal to it is going to be in a collapsed state. Now what has happened is the content has moved here. So the bowel which was present contracted here has moved back to its normal location, And the bowel which was distended here has now recoiled back to its normal level. This recoil pressure is what we call it as secondary contraction. So whenever there's an alternate primary, secondary, the content will continue to move in the forward direction. This is how it occurs. Now imagine where you have a lead point. At the lead point, if there is intense primary contraction, imagine what is going to happen. Now because of this intense primary contraction, the diverticulum which was evaginated is now going to become invaginated because of contraction. Now the diverticulum has become inwards. So there was a severe contraction here. No, the bowel wall was getting compressed. Under the compression, now the diverticulum has become ulta. Okay, it is now invaginated. Obviously, the wave of peristalsis is moving in this particular direction because that is how the content is supposed to go. Now imagine if the wave of peristalsis is moving this way and the content which is present here has now come across here. Okay. So what is going to happen? This content that is being present here will now push everything forward, including the diverticulum. Okay. It is exerting pressure on the diverticulum, so this is everything is pushed. So imagine if I hold this and I pull it like this. मैंने इसको पकड़ा ऐसे और आगे की तरफ खींचा, तो खींचोगे तो क्या होगा? ये आपका proximal end था, ये आपका distal end था. Now when I pull, now imagine if I tie a knot here and then I'm pulling it like this. What is going to happen? It will pull this entire bowel in the same direction. The pura it is going to pull up. Now this lumen is continuous. Okay? So obviously the opposite end will also be pulled. Okay? Because ये पूरा एक ही luminal wall है. It comes out through and through. And because of this, the proximal end of the bowel with the lead point is now going to move into the distal end, and the distal end is now going to accommodate, and the point from where it starts, this is your Meckel's diverticulum. The point from where it starts is what we call it as lead point. So this is your proximal end of the bowel, this is the distal end of the bowel, and this is what we call it as intersusception. Is that clear? Those who are not able to comprehend, just give me a second. I will show you in the demo form also. Hold on for a second. Okay, I tried to get the working model. It was not working, so I found an alternate. Okay, so let's see if we are able to achieve something out of it. Exactly. Okay, let's see if it works. Now, this is the loop of the bowel that we are trying to tell you. This, let's say there are two parts of it. I'll say the proximal and the distal end. We'll make that also. So if I just split that into the center, ठीक है, तो ये point हो गया, ये पहला वाला proximal end हो गया. So we'll say this happens to be the proximal end and D stands for distal end. ठीक है, तो ये आपका proximal end है, ये आपका distal end. So what is going to happen is the lead point is somewhere here. ठीक है, so I'll just say the point from where the intersusception starts. The point from where the intersusception starts, take this as a lead point. Now that lead point can be a Meckel's diverticulum, it could be a polyp, it could be a hypertrophied mucosal folds, anything that can happen. Take out Peyer's patches. So what is happening is this part is now going to go inwards. ठीक है, lumen के अंदर की तरफ जा रहा है. Now if this goes inwards, what is going to happen? This part of the lumen gets collapsed. It goes inwards. अंदर की तरफ चला गया. Now as it goes inwards, ये अगर अंदर जाएगा तो क्या होगा? You can see inside the lumen. ठीक है? It goes inwards. So the whole lumen, because the entire wall is together, because it's a paper form, it's very difficult for me to push it. We try करते हैं. अगर बन पाया तो ठीक है. Getting quite difficult, not happening. आज का मॉडल थोड़ा फेल रहा, but try करें. Okay, something I'm able to achieve. ऐसे होना छोड़ दें. So you can see this end of the bowel has gone inward. ठीक है, तो ये जो आपका proximal end of the bowel था ये अंदर घुस गया, तो obviously ये अंदर घुसेगा, it will go like this. ठीक है, now as it goes into the distal end, the proximal end of the bowel has gone into the distal end. What has happened to the lumen? See, अंदर पूरा block हो गया ना. That clogging occurs because the proximal end goes into the distal end, and this is what we call it as intersusception. ठीक है, इसी को आप intersusception बोलते हो, right? Now, whenever a patient presents to you with intersusception, what are the clinical features? ठीक है, so we'll run through the clinical features of intersusception. Now, let it be any component, patient will present to you with signs and symptoms of dynamic bowel obstruction. We have discussed previously also, when you talk about the signs and symptoms of dynamic bowel obstruction, it will be associated with colicky abdominal pain. It will be associated with the colicky abdominal pain, nausea, vomiting, non-passage of stools and flatus, non-passage of stools and flatus. And when you evaluate, you will see there will be presence of bowel sounds. There will be presence of bowel sounds, right? Especially in children, no. in age between 6 to 10 months, the typical presentation, the baby will start crying intensively, the baby will be restless, the baby will have the legs flexed, and the baby will continuously cry. Obviously, looking at all that, the mother gets worried, and when the mother looks at the abdomen, it looks a bit distended also. Baby is vomiting, mother gets scared, rushes to the hospital. By the time she reaches the hospital, baby starts to play again. Baby is again normal, fine and all, and mother is puzzled. As a pediatrician, you should never let go that baby who had been rushed to the hospital because of extensive cry associated with vomiting and abdominal distension. Always open up the diaper and see. What will you see? There will be presence of red currant jelly stool. Basically, red currant jelly stools. The red currant jelly stools indicates interception is resolved. So this indicates a resolution. This indicates a resolution of intersusception. This indicates the resolution of intersusception, right? In fact, when you palpate right iliac fossa in children associated with intersusception, you will see presence of empty right iliac fossa, which is also called as Dan's sign positive. Right. Now, when I say the proximal end is going to distal end, the proximal end is going to distal end, where does it actually go? If I ask you the most common type of interception in children, most common type of intersusception in children, IC in children is ileocolic. That is why you have empty right iliac fossa. Same thing if I ask you the most common type of interception in adult, the answer is going to be colocolic. It is a colocolic, right? Correct. Dan sign is absolutely spot on. Okay. Achha. Now, obviously, when the baby is presented with all these features and when you like to investigate, the first investigation is going to be an erect X-ray abdomen. In an erect X-ray abdomen, you will see presence of multiple air fluid level. So when you talk about intersusception or obstruction in children, you can also give barium enema to look for it. In a barium enema, classically, what would you see? There will be claw sign. Now, what is this claw sign in children? If you have to interpret it, let's say this happens to be the descending colon, the transverse colon, and the ascending colon, which is present here, right? This is the objective. This is the sigmoid, this is the rectum, and this is the anal canal. In an interception, you see the ileum has gone inside the cecum, and this is how the interception looks like. This is the ileocecal interception, and this is the rest of the small bowel that is present. I'm not worried about it. So what we do is in enema, I'm going to flush the enema from here, right? So this is where the enema is given. Now imagine that the enema which you're going to give is going to travel via the anal canal, goes into the rectum, from there into sigmoid colon, from the sigmoid colon into the descending colon, from the descending colon into splenic flexure, from there into transverse colon, from there into your ascending colon, and here it comes and then get blocked. So what you can see in an X-ray, you cannot see the bowel wall, you can only see this barium enema, or I can say the barium which you can see in an X-ray. So when you interpretate the barium, this is how the barium would actually look like, right? So you can see the barium is getting caught up here. You see the whole barium is flowing. At this point, you see the barium is getting clogged up like this. This is the whole barium that you can see here. And this is what we call it as the claw sign. So it looks like claw because the barium gets clogged there. So this is how the claw sign would actually appear. This is how the claw sign looks like. Most of the children will do an ultrasound. So the investigation of choice for interception in children, it is going to be ultrasound abdomen. Now in the USG abdomen, what do you see? You will see presence of, on an ultrasound, there will be target sign and there will be pseudo kidney sign. The pseudo kidney sign. Remember, in adults, for all intestinal obstruction, investigation of choice in adult, for all the intestinal obstruction, it is going to be CCT abdomen. It is going to be CCT abdomen, right? Now, once you have clarified that the patient is having intussusception on an imaging, how would you like to manage? So management protocols are going to vary whether you're addressing a child or an adult. Whether you are addressing a child or an adult. The protocol for child is you will initially give enema in view that it might resolve intussusception. I will give first attempt as air enema. If it does not resolve, I'll repeat with air. If it does not resolve, the third one is going to be barium. So this is the sequence of enema. So total 3 attempts of enema can be given. There is 3 attempts of enema can be given. If it fails to resolve, even after giving enema, if it fails to resolve, this is an indication for exploratory laparotomy. This is an indication for exploratory laparotomy. In adults, there is no role of enema. Take the patient directly for exploratory laparotomy. Take the patient for exploratory laparotomy. See? Pankaj, you're correct. Air enema is what we call it as the pneumostatic reduction. If it does not work, then hydrostatic reduction. So 2 attempts of pneumostatic reduction followed by 1 attempt of hydrostatic. If it does not work, take the patient for exploratory laparotomy. Now, what is the protocol that we follow in an exploratory laparotomy? When you perform an exploratory laparotomy, in exploratory laparotomy, identify the site of intussusception. Once you identified it, then resolution of intussusception. Now, what do you mean by resolution of intussusception? Resolution of intussusception basically means the bowel loop which is being present inwards like this, you have to relieve it, right? So how do you relieve it? So this is the proximal end of the bowel. This is the distal end of the bowel. We never pull. You should never, if it is the proximal gland, you should never pull it. What we do is we exert gentle pressure from the distal end towards the proximal end. This is what we call it as milking of bowel. This is milking of bowel from distal to proximal end. From distal to the proximal end, and then gentle traction at proximal end. At the proximal end for the intussusception to resolve. So gently you will hold it and then you exert pressure from the distal end towards the proximal end. You're just like basically milking it and then the intussusception will resolve. Okay? Now, once the intussusception is resolved, what are you going to do? Now, there are 2 things that you're going to check across it. The first one, the part of the bowel which was under intussusception, you are going to inspect. So let's say this part of the bowel was the one that has participated in the intersusception. So the first question is this viable or non-viable? Whether this is viable or whether it is non-viable. Non-viable basically means if there is any necrosis of the bowel wall or if there is any gangrene of the bowel wall, then it will be considered as non-viable. If it is non-viable, then you have to perform a temporary ileostomy. Perform a temporary ileostomy and then you can go with reversal later. In a temporary ileostomy, basically what am I going to achieve? If this is the esophagus, this happens to be the stomach. Let's say this is the duodenum, this is the small bowel, that is your jejunum, and the ileum. Now the part of the bowel which was completely been damaged, I have excised that end of the bowel, and let's say this is the abdominal wall. What I'll do is the rest of the bowel that is present, that is, let's say, the ascending colon, the transverse colon, the descending sigmoid and rectosigmoid, what we'll do is we will take a temporary stump closure here, right? Or usually if it is associated with the distal end of the terminal ileum, so the ileum is closed, and this part of the ileum which is left behind, this part of the ileum which is left behind will be now opened onto the abdominal wall. It will be opened onto the abdominal wall and we will connect to a fecal bag. This is what we call it as ileostomy. Okay? So ileostomy is done and later on you can go with reversal. I will not do it immediate because the bowel is not prepared, contamination can occur, anastomotic leak can occur. So to prevent all that, I will only go with ileostomy. It is a ileostomy. Buran, it is BLS series. We have remember all these. बेटा steps की जरूरत नहीं है, but then you should know the end point that what are you going to achieve. ठीक है? Hi here. Good evening. ठीक है? चलो. If the bowel wall is viable, ठीक है? कोई necrosis नहीं, कोई gangrene नहीं, it is viable. In a viable status, we see is there any lead point available? We'll see is there any presence of lead point. Presence of lead point, absence of lead point. If presence of lead point, then you have to take the bowel for resection and anastomosis. We usually excise the lead point. If there is no lead point, then do nothing further. This is the whole objective of management of intersusception. Hi Aditya, 3.0 is, I think it is going to be live from this week onwards. Today was the day that the official launch was announced. So I think by this week onwards, you'll get the role. All those guys who have the Meded app, I would request you to update the app because you will get the newer version that is 3.0. It is amazing. We have done a lot of new things, especially if you go to the first, second year, you will be amazed. Trust me, you will have a lot of surprises. There are English videos available. जिनको language का issue है उनके लिए हिंदी इंग्लिश के combination में एक lecture and pure English का lecture अलग है. Our Ranjit sir, you know, like predominantly a South Indian, लेकिन उनने भी हिंदी में record किया है. Go watch it. It is amazing on that side. Pradeep sir has done amazing dissection videos. पूरा anatomy का dissection, on table dissection is available. I would recommend you to go watch it. ठीक है? Yeah, anybody who has it, just you need to go and re-put it again. Update करना पड़ेगा app to get you the newer content. ठीक है? चलो, so this is all in all with respect to intersusception. Again, a very, very important topic. छोटू topic था, but it had its own significance. So very important. ठीक है? बेटा update will roll from tonight itself, तो कल मिल जाएगा आपको. ठीक है? चलो. So this is all in all with respect to intersusception. कोई सवाल, any question, any feedback, anything that you want to ask? किसी को कुछ बोलना है, कुछ कहना है, कुछ complain करना है? Except for the fact कि sir last week you did not take BLS. बेटा मुझे भी लेने का मन तो है, लेकिन क्या करें, कुछ some days are not under your control and some days technicalities is also a problem. बेटा लीड पॉइंट आप when you unwind the bowel ना, जब आप इंटरसेप्शन वापस करोगे तो मेटल जाइवेटिकुलम एक लीड पॉइंट है, वो आपको पता चल जाएगा. अब बाउल पैल्पेट करके देखो ना, अंदर कुछ आपको ग्रोथ लग रहा है, पॉलिप जैसा है कि नहीं है, देन यू सी इफ देयर इज मिसेंट्री उसकी थिकनेड है कि नहीं है. सो दैट्स इट्स इजी एज अ सर्जन, you put your hand, you palpate, you get to know. Ravi, for NEET SS, I would say, see, what BLS is a series where we go in depth about the subject. I'm not differentiating whether you are an undergraduate or a postgraduate. For a postgraduate level, these are basic minimum that you should know. On top of it, that you have to build for NEET SS. So this alone is not enough, but this is a very good resource for your residents as well as NEET SS also. Clear है? और कोई सवाल? I've recently entered third year and I want to complete surgery in this year. How should I approach? Burhan, for you, the ideal approach is to start reading the textbook. That is your Bailey and Love. If the time does not permit, BLS is an excellent source. By the time you see BLS, I think we have done more than 85 odd videos, that is 85 hours. By the time you cover 85 hours of content, would have finished the entire Bailey and Love. So BLS is a good, adjuvant for that. Keep your textbook with you. Start reading. See, in the first reading, you will never be able to understand things, and that's why we have BLS series, so that the understanding comes with the first reading. Uske baad, when you do the second reading, you will have much better, consolidation and understanding. And third reading, you'll be able to remember the things as well. 140 आया है, start कर नहीं हो रहा सर, आई डोंट नो व्हाट टू डू. पंकज, यार ये सबके साथ बहुत कॉमन है. मैं आज आपको बता रहा हूँ पंकज, एक बात आप लिख लो कि अभी से एग्जाम के लिए 130 दिन और बचे हुए हैं. ऑल दैट यू हैव टू डू, दो बातों का ख्याल रखना. हो गया जो हो गया, उसके बारे में हम कुछ नहीं कर सकते. दो चीजें जो आपको याद रखनी है. नंबर वन, ना इधर की सुननी है ना उधर की सुननी है. पुट योर हेड डाउन एंड वर्क. और कोई भी इससे बेटर एडवाइस नहीं है. ठीक है, आपके दोस्त क्या कहते हैं, आपके फ्रेंड्स क्या, योर टीचर्स क्या कहते हैं, फैमिली वाले क्या कहते हैं, डजंट मैटर. ऑल दैट यू हैव टू डू इज डेली सुबह उठना है, उस किताब के आगे अपना मुंह रखना है, सर नीचे रख के वही किताब पढ़नी है. सो पुट योर हेड डाउन एंड वर्क. दैट्स द ओनली एडवाइस दैट आई एम गोइंग टू गिव इट टू यू. फ्रॉम हियर ऑनवर्ड्स हर दिन मिनिमम 100 MCQs करने हैं बिफोर यू गो टू द बेड, वरना सोना ही नहीं है. इफ यू डू दैट, मैं बता रहा हूँ बेटा, आपके एग्जाम का जब रिजल्ट आएगा, विल मीट अगेन ऑन द BLS सीरीज एंड देन यू विल टेल योर सक्सेस स्टोरी. और वो कुछ 150 160 का स्कोर नहीं होगा, 220 230 का होगा. ठीक है, द वे यू आर आंसरिंग, आई हैव बीन सीइंग ऑन द चैट बॉक्स, यू आर गुड. बैड लक सबके साथ होता है, ज्यादा उस पर दिमाग नहीं लगाना है. ठीक है, सिट टाइट, वर्क हार्ड, डोंट ऑल्टर योर सोर्सेज, डोंट कीप ऑन चेंजिंग योर सोर्सेज. एक मटेरियल पकड़ो, उसी पे लगे रहो. MCQs करो, PYQs करो, PYTs करो, and make sure you are not being caught up with all, जो बहुत सारी चीजें आपके अराउंड चल रही है कि ये भी कर लेते वो भी कर लेते, यहाँ का रिवीजन वहां का रिवीजन, ये वो ना. स्टिक टू वन प्लेटफॉर्म, वन सोर्स. Make sure you do it again and again. Repetition, revision is the key. Solving MCQs is the key. 100 questions per day. Repeat, revise at least 3 times every subject, all 19. मैं बता रहा हूँ बेटा, 220 225 कहीं नहीं गए. Don't worry about it. ठीक है. Pawan, Bailey and Love is basic for UG. For all the residents, if you join general surgery, you should basically be able to imbibe Bailey and Love is bare minimum. तो ये जो मैं पढ़ा रहा हूँ, ये हर उस अंडरग्रेजुएट के लिए है जो अभी MBBS कर रहा है. और this is the bare minimum that every postgraduate who has started should know. So this is like a bridge between the two standards. बेटा, that chocolate red currant jelly stool is because of mucosal shedding. वो mucosa crush हो जाता है, जैसे वो resolve होता है तो वो shed होता है. Mucosal shedding will result in red currant jelly stools. बेटा क्लिनिकल बेस्ड क्वेश्चंस आर द इजी वन, उस पे आपको प्रैक्टिस, सी व्हेन यू स्टार्ट सॉल्विंग क्वेश्चंस विद प्रैक्टिस यू विल अंडरस्टैंड कि हर एक क्वेश्चन का अप्रोच अपने अलग तरीके से होता है, ठीक है। व्हेन यू स्टार्ट सॉल्विंग द क्वेश्चन, मेरे पास एक सवाल है, एक सेकेंड, फॉर एग्जाम्पल लुक एट दिस क्वेश्चन। ये क्वेश्चन आप जब तक नहीं करोगे तब तक आपको समझ में नहीं आएगा, हमने लास्ट टाइम भी किया था। इफ आई शो यू दिस क्वेश्चन, इफ आई शो यू दिस क्वेश्चन, अगर आप ध्यान से देखोगे ना, सवाल बोल रहा है कि पैथोलॉजिकल कंप्लीट रिस्पॉन्स इन नियोजेन कीमोथेरेपी इज मोस्ट कॉमनली सीन इन विच सब टाइप ऑफ ब्रेस्ट कैंसर। तो जब आप सवाल देखोगे आपको लगता है कि पैथोलॉजिकल रिस्पॉन्स होना, इसका मतलब है अच्छा प्रोग्नोसिस होना। अच्छा प्रोग्नोसिस आप ल्यूमिनल ए में देखोगे तो आपका आंसर बन जाता है ल्यूमिनल ए। लेकिन बेटा कॉन्सेप्ट क्या है? कॉन्सेप्ट ये है कि कंप्लीट पैथोलॉजिकल रिस्पॉन्स इन अ ब्रेस्ट कैंसर इंडिकेट्स द ट्यूमर इज डिसअपियरिंग ऑन स्टार्टिंग कीमोथेरेपी। मतलब कीमो बहुत इफेक्टिव है। कब इफेक्टिव होता है? Whenever a cell is able to proliferate aggressively, because of that aggressive proliferation, it is actively proliferating. उसका cell cycle active है. All your chemo agents work on that cell cycle. They arrest the cell on that cell cycle. उसका मतलब क्या है कि अगर chemo agents काम कर रहे हैं, cell actively proliferate कर रहा है. And in a triple negative, it's a very aggressive growth, and because of that chemotherapy acts very well and the tumor completely disappears. ठीक है, तो complete response का ये मतलब नहीं है good prognosis है। complete response का मतलब actively proliferation है। in fact complete response is more warrantfully examined and followed up for the patient after the surgery। तो यहाँ पे आंसर ट्रिपल नेगेटिव ब्रेस्ट कैंसर है। तो यहाँ पे कंप्लीट पैथोलॉजिकल रिस्पॉन्स ऑन कीमोथेरेपी इंडिकेट्स एक्टिवली प्रोलिफरेटिंग डिजीज, एंड एक्टिवली प्रोलिफरेटिंग डिजीज इज एन इंडिकेटिव ऑफ ट्रिपल नेगेटिव ब्रेस्ट कैंसर। ठीक है, तो ये जो कंपोनेंट मैं आपको समझाने की कोशिश कर रहा हूं कि सवाल जो है सवाल की तरह ही दिखेगा आपको। ठीक है, सवाल जो है सवाल की तरह दिखेगा until unless you don't start solving questions। वही चीज है बेटा, इट इज ओल्ड वाइन इन न्यू बॉटल। पैकेजिंग बदलती रहती है, देखने का नजरिया बदलता है, लेकिन कॉन्सेप्ट नहीं बदलता है। Start applying it as you start solving more questions, you will become more strong on that behalf। ठीक है, chocolate, I want to create the schedule for BLS, लेकिन बेटा you need to consider two things from my end। I'm a practicing surgeon, so lot of these days where I have a major OT or where I have a typical case, those days I cannot really commit। मतलब Monday Tuesday Wednesday हमने सोच के चला था कि हम BLS हम चलाएंगे, लेकिन कभी कभार क्या होता है कि मंडे इज माई मेजर ओटी डे एंड वेडनेसडे इज माई मेजर ओटी डे। तो दोनों मेजर ओटी डे के दिन होता है, अगर पेशेंट ठीक है फिर तो BLS आराम से चला लेंगे, नहीं तो फिर दिक्कत होता है। देन ऑल्सो आई हैव माई टीचिंग कॉम्पोनेंट, जो वी डू इट फॉर मेडेट, आई हैव अ लॉट ऑफ रिकॉर्डिंग्स फॉर देम ऑल्सो, दैट ओवरलैप्स। तो मैं अपने हिसाब से स्ट्रगल कर रहा हूँ, आई एम ट्राइंग टू हसल, ट्राइंग टू क्रिएट, क्योंकि BLS ना, as I keep telling, it is my dream project। I wanted to start this so that I can teach one textbook in toto available on YouTube for free for every single kid who wants to learn general surgery। So that's something that it's very close to me। I'll try to create a schedule, we'll try to stick to it, but थोड़ा आपको भी मेरे एंड से ना फ्लेक्सिबल रहना पड़ेगा। हमसे पूरी डिटेल्स बता देते हैं, लेकिन उसके आगे क्या, पंकज लेट्स नॉट ओवरथिंक इट ना बेटा, सवाल करते हैं। आप एक काम करो, जब भी किसी भी सवाल में फंसते हो आप स्क्रीनशॉट लो, मुझे मेरे टेलीग्राम ग्रुप पर डाल दो, कोई दिक्कत नहीं है, मैं आपको ऑडियो नोट भेज दूंगा उसको कैसे संभालते हैं। Every single student who is solving questions, if you're not able to get an answer, all that you have to do is to take a screenshot of that particular question, send it to me on a telegram, just tag me and say sir मुझे समझ में नहीं आ रहा है। I will send you a personal audio note for that particular question so that you understand and solve better, so don't worry about it। Chocolate, we can do that, we'll do that। Thank you SP beta, you are in 11th class and if you're watching my lectures I am actually amazed। ठीक है, तो all the best crack your NEET UG as early as possible, get into a good medical college, फिर आके खूब सारी पढ़ाई करेंगे, कोई दिक्कत नहीं. चल. So loads of love to all of you. Thank you so much for joining. As we've been doing BLS for a while, you will notice that as we continue to go, BLS will evolve. Okay? This is something which is going to be really close to our heart. We're not going to stop it. We're not going to end it. We will only make it better from here on. We'll try to do, I thought I'll do a marathon series, but the time did not permit me for covering up for the last week. We'll do it. We'll do it slowly and steadily, but we'll definitely do it for together, right? Thank you so much for joining today. Have fun. We'll resume back tomorrow at night 10 o'clock. Until then, goodbye. Take care. Have fun.